Unfit patients, that's the category where we would reduce chemotherapy, and that's done with very little chemotherapy, we think. Next one. So one of the trials that was mentioned this morning already is with a novel antibody, so increasing the immunotherapy component and reducing the chemotherapy with a very mild agent like chlorambucil, known for, as you have seen, more than 60 years. The novel antibody is G101 or obinutuzumab, highly acting, has a different mechanism of action because it's a type 2 antibody. It's not forming these cellular adhesions and killing cells directly. And I think the most convincing picture I can show you is the next one, showing the efficacy in our trials and in the publication. So if you use obinutuzumab in CLL, it sometimes takes a few hours or one day, and the leukemic cells in the blood are gone. And this is 6 patients from a run-in trial, and we had a phase 1/2 trial. Whenever we used this antibody, we were surprised about the tremendous efficacy. There's not another single antibody that is so potent in CLL as this one. And the cells basically disappear very, very quickly. And that's explaining also its major side effect, that is the tumor lysis or cytokine release. So we did a phase 3 trial, and I'm going to show you quickly the results. So this trial is comparing chlorambucil, which is the standard for these non-fit patients in Europe, versus obinutuzumab, the novel antibody plus chlorambucil, versus rituximab plus chlorambucil. So 2 anti-CD20 antibodies, the novel one and the old one, rituximab, obinutuzumab. 3-arm trial. And as you can see, chlorambucil is rarely inducing remissions in the literature between 30 to 50%, and this number is increased by the addition of the antibodies. And the lighter blue parts tell you that we even achieve complete remissions with obinutuzumab or G101 to a much higher extent than rituximab, only 7%. So here again, indication of a higher efficacy of G101. Next one. So then we compared, does that change the outcome? And again, and surprisingly, G101 plus chlorambucil yields a survival difference compared to chlorambucil, and this is in an older population, median age 70 years. I will show you some data. So one could say, I'm never saying this, but one could argue, well, in this group of patients, who cares? You know, you can start with anything, and they will die of heart attack or something. Yeah, but this is simply not true. If you treat CLL correctly, you change, in the first place, the initial treatment, you change the likelihood, you improve the chances to survive, which is, I think, an important finding in this population as well. Next one. The same, less potent though, is true for rituximab. So today, it's no longer appropriate to simply do chemotherapy in CLL. Even in the elderly population, in the patient with reduced fitness, you should add an anti-CD20 antibody. Next one. Now, the important comparison is, of course, is the novel antibody better than the old one? And this is shown in this stage 2 analysis, which we had to do a little later because it required more patients. And if you would just simply look, please, at the patient's characteristics, because I think this trial is important for this feature. So they had an age above 65 in more than 78%, an age above 75% in more than 40%, both arms. The SIR score, which is indicating reduced fitness and high comorbidity, was above 6 in 75%. The creatinine clearance, which is showing your kidney function, was reduced in more than 60% in both arms. So in other words, with a little exaggeration, these are patients that would normally be excluded from clinical research. We are usually not doing trials in these patients because that creates all kinds of troubles and problems, and you can't really see what's happening. This is real-day patients, really real-life patients. And that's why this type of trial is so important, because it really shows, can you have an impact in the population of the majority of the patients that have additional health problems. So again, and then now the comparison of the 2 antibodies, MRD, so the clearance of these leukemic cells from the blood or from the bone marrow, and again, the novel antibody is clearly superior, as you see in both comparisons, 38% versus 3% in the peripheral blood. And the progression-free survival is highly different with rituximab 15 months and with G101 or obinutuzumab 29 months. So you're doubling the time to retreatment in the majority of the patients, or to progression. Retreatment comes even later. Overall survival, there's a trend, but so far no difference. Maybe we have to wait a little longer. This is a fairly young trial still, and survival differences usually come up a little later, and this remains to be seen. But we will follow all our patients until the end of their life, so that in this German study group, we will, if there is something happening, we will see that. Side effects. To cut a long story short, the major difference in side effect is a transfusion-associated initial reaction. So the infusion-related reactions called IRRs, second line, explain the difference and explain why we have more side effects with G101. And importantly, those reactions disappear. You can see both arms here and the numbers of these infusion-related reactions in both arms. And you can see that G101 is inducing a high number of these reactions, but only the day 1 and day 2 of the infusion. And then it disappears and doesn't come back. Rituximab, it can eventually come back at the second course. So it's a typical effect of these antibodies. It just emphasized, is augmented in patients treated with G101 because it's more potent. So it's killing CLL cells so efficiently that the cytokine release is a problem in the initial phase, and you have to overcome and know how to handle this. There is another antibody, ofatumumab, also against CD20, so the third one that is approved for CLL, and has also shown to be superior to single agent in this trial here that was just published in The Lancet a few days ago, and shows you a similar feature. Unfortunately, they did not compare to rituximab, so we don't know whether ofatumumab is really better than rituximab for the treatment of CLL. It is certainly better than chlorambucil, and again, showing us that the time of single-agent monotherapies or chemotherapy is over in CLL. That's shown by this trial as well.